My name is Catherine, and today we're going to be looking at Leslie's IUD. So essentially, we're starting with a transabdominal ultrasound, and I start with a longitudinal view, which means we are having the notch up toward Leslie's head, and orientation on the ultrasound machine screen. I'm going to turn up the gain so we get a little bit more brightness. So we have, this is Leslie's toward her head, toward her feet. This is the anterior aspect, which is the skin line, and toward the back. And we can see a lovely anterior anteverted uterus. So I will select my cursor, and we can see a bladder here. I'm going to turn the gain just down a tad bit. So I'm pressing down on her abdomen, and the indication is to evaluate the placement of the IUD. She has a Paragard IUD, so it's a copper, so it's more dense, so we're going to get brighter echoes for that. So this is a really excellent view to show the placement since it's so nice and bright. So essentially, this is the fundus. I'm going to zoom in the image to make it a little bit easier for the folks at home. There we go. Zoom again. There we go. So here is the top of the uterus. This is the posterior aspect, and this is the cervix, and this is anterior. So we're seeing a lovely IUD in the fundus and in the endometrium placed nicely. I'm going to freeze the image and measure the length first. So we'll go to measure, and we have to change this parameter to gin, and we'll go to the uterus.
And I've seen it both ways, where some people will relax the probe while they're freezing the image, and some people's opinion is hold it exactly there, because when you release, you're gonna, if you're having a hard time with orientation, I've seen half and half with the instructors, where it's like hold that spot real firm exactly, even though you freeze it. And some people are like, relax your arm, give a break. So do you have an opinion on one or the other version?
I think in the beginning it's a good idea when you're first starting to scan to probably hold it down.
Okay.
But as time goes on,
and you know how to get back orientated quickly.
It helps keep the ergonomics where your muscles are getting a break.
Yep. Okay.
So yeah, that's a good point. Thank you for bringing it up. So I'm going to bring up the cursor up to measure at the top of the uterus. And I'm going to go straight down through the endometrium, down to the external os, select set. Then we're going to do the height of the
So how did you know that first line was the internal or external versus the lower line? How did you know the difference?
So this bright echo here is telling us there's a change in interface.
Okay.
So the sound waves through the soft tissue, and we have a surface change that makes it brighter because of the change of ultrasound speed.
Okay.
So next I'm going to measure the height of her uterus, and again, here's the brightness of the interface that's telling us this is the anterior aspect. I'm going to select set, and we're going to be measuring a perpendicular measurement. So we're going to make when we're eyeing it, we're making an imaginary perpendicular view. And again, here you can see this is a little bit darker, meaning it's hypoechoic. And here's the interface to the back posterior aspect of the uterus. And then I select save. And now I'm going to unfreeze. And to measure the uterus, we're going to turn 90 degrees. So I have my orientation correctly, making sure I'm in the longest part, and now I'm just going to turn where the notch is going to be at 9 o'clock. So this is the top of the uterus. You can see the interface there. And the Paragard is actually giving us kind of a guide where you can see the arms of the IUD. So in the orientation of a transverse view, it says if you're looking at the patient, this is the right of the screen, this is the left of Leslie. Anterior, posterior stays the same in the orientation.
Perfect. And the biggest thing is you're looking for is that there's no perforation of the IUD into the endometrium, and like we had talked about many times with the students is normal. Once you see abnormal, it's easy, but obviously during the volunteering, and we hope that none of the people volunteering have that rare situation. But
exactly. So this is going to be our widest diameter of the uterus kind of view, giving an overall look. And I'm going to select measure. It brings us to uterus width, brings up the caliper, and I would eye it. So starting up at the top of the uterus, you can see the line there, and then where there's kind of a difference in the interface here. This is a little bit of brighter echoes, a little bit darker, so we're getting more into the myometrium. So I'm going to select set and go straight across to the left of the screen, to the left of the uterus, and select set. So that's how we measure uterus. And you can see the volume up here on the screen, and it gives us our length, height, and width. I'm going to unfreeze. So we're looking at the full placement of the IUD. This transverse is the gold standard to evaluate the arms of the IUD. So you can see the arms here, and it's equal distance from in the myometrium from the wall of the right aspect and the left aspect. And now I'm angling toward her feet so you can see the stem nicely, and it's in the center of the endometrium. And then you can sweep down toward the feet, and you can see Leslie's cervix, and there's the interface that shows this is the
once in a while we
os.
could see the string, but it's so rare because it's so tiny.
It's very rare.
Yeah, so a lot of practitioners will be doing the abdominal IUD viewing because the string, they can't feel it. You're not able to visualize. This is a simple thing you can do in the office. If they're having pelvic pain, you can just confirm the IUD is in the correct placement. Once you get good, it'll take you 2-3 minutes max to do the point of care, but as you're practicing, you just go slow and take your time. So
that's exactly right. And so I'm pressing quite a bit to help get some of any type of bubbles away from.
Yeah. And the viewing is going to make a difference whether they're antiverted, retroverted. The way you may not be able to do it from their abdomen if they don't have a full bladder. They're retroverted, so I'm antiverted and I have a full bladder. So it was optimized, but sometimes you can't control that with the patients in the situation that comes in. But thank you so much, Catherine, for showing us today.
Yeah, I'm happy to help.
Okay.
Thank you.